where my job at CADTH is basically to check big pharma's homework. They want provincial drug plans to adopt new drugs and fund them through public insurance. And so the question becomes, are we getting good value for what we're being asked to spend? Does the evidence actually support this decision? And so much of the work that we do at CADTH revolves around the use of economic models and understanding what is in those models, not only from the numbers kind of sense of it, but also what are the values that are reflected in those models, and what kind of decisions are we making, and what kind of decisions are we not making as a result of assumptions that are sort of baked into a mathematical analysis. And so today, what I'm going to do is walk you through, just to give you a bit of a grounding in what economic models are, what they're for, and how we use them. Before we get started, I just want to make it clear that the information that I'm presenting here is not necessarily CADTH policies or positions or opinions. These are my own reflections as a health economist, and they aren't necessarily reflective of my employer. I also have no relevant conflicts of interest to disclose. I don't take funding from any group other than my employer. So yeah. So we are trying, with health economics, we are trying to solve a basic problem, which is that there are limited resources available in the healthcare system. And there's new stuff coming onto the market all the time. Drug companies are making new things, device makers are making new things, there are new procedures, new programs, all kinds of new things that are coming on the market to solve healthcare problems. And we can't necessarily, we have a finite budget. And this is the issue that we have to confront. We have high levels of need and new things come in the market all the time, but a limited ability to satisfy that need. And so we have three possible responses to this conundrum. One is that we can just pay for everything. We can just say, anytime someone comes up with a new thing, we're going to pay for it because we want to have the best, most cutting edge, highest tech healthcare system possible. The problem that we run into there is, where does that money come from? How could we possibly pay for everything under the sun? The other related question is, some of the stuff that just because it's new doesn't necessarily mean that it's better. It just means that it's new. And we know, not to disparage my colleagues in industry, but just to recognize that there are lots of different ways to make an argument for something being better than standard of practice. And it's not always the case that it is better. Sometimes it's just newer. The other option is to say, or another option is to say, no, we have a good enough healthcare system as it is. We don't need any of this newfangled business. We'll just stick with what's currently working, and all of this new stuff can, someone else could buy it. That we are going to miss out on a lot of potential opportunity, because there is a lot of new and interesting and valuable innovation, and the industry is really trying to take into account the needs of patients, the needs of families, the needs of public health. And if we just say no to everything, we miss out on any potential opportunities for benefit that may result. And so the third option is, okay, we're going to say yes to some of the things so that we can get these benefits. And we're going to say no to some of these things so that we're not spending a lot of money on stuff that doesn't work very well. So then the question becomes, okay, but what are the things? How do we decide what we say yes to and what we say no to? We can't, there's no obvious solution to just, well, we'll just pay for the good stuff. Okay, but how do we define that? And so economic evaluation, health economic evaluation, proposes a set of rules for how to make these decisions that are guided by generally speaking, three questions. First, how much better is this new thing that we're considering funding? How much better is it than what we're currently doing? We have a treatment for a headache. How much better is that than what we currently have to help manage headache? The second question, of course, is how much more does it cost? How much more are we being asked to spend above what we currently, what our current budget is? And then the third question is, is it worth it? Are we getting good value for that additional money, good additional benefit for the additional cost? And by making decisions in this way, health economists argue that we are helping the healthcare system to buy, and I'm being very loose in that sense because it's not quite the same as a market good, but to help the healthcare system buy the most health for the population so that we are making sure that for each additional dollar that is going into the healthcare system, we're getting the most out of that dollar, the most bang for the buck, so to speak. So I'll give a very facetious example outside of healthcare here. Let's say that you're thinking of upgrading your phone, and there's a new phone, the iPhone 15 or whatever number we're at now, coming onto the market, and you're thinking about, oh, maybe I'll get the upgrade. So you might ask yourself, what am I getting? What exactly is the value of getting the new thing? There might be a lot of new, really cool features. Like when I last upgraded my phone, it has this really good nighttime camera, and I go to a lot of live shows in concert venues that are pretty dark. So having a camera that has a really good light sensor is actually a really big value for me. But also maybe your current phone, maybe you're still using a Nokia flip phone, and it's just not smart enough. It doesn't have enough capacity. And so if you've got a lot of new stuff that's really good and the current thing that you're using is not that great, there's a very high incremental benefit. There's a big value that you can get for making that upgrade. And then the question becomes, how much more are you being asked to spend? Maybe you're on a plan, maybe you're with a provider that offers you a heavy discount on the phone, or maybe someone's giving it away for free, or whatever it is. You may see this as having a low incremental cost or a high incremental cost. It might be an extra $1,500 that you're being asked to spend if you're buying a brand new phone outright. And so each one of you has a specific, theoretically, an amount of money that you personally are willing to pay so that you could have this new phone. And the question that you need to ask yourself is, what else could you spend that money on? Should you spend your rent money on a new phone? Probably not. And if all you have in your wallet is rent money, then your willingness to pay is going to be quite low. Whereas if the marginal benefit is very, very small, maybe that cost is not worth it to get the new phone. So this is all fairly intuitive, and I don't think I need to go into a ton more explanation. But these are the kinds of questions that we ask. We just do this in the healthcare setting. And so there's a very important question to ask, which is, how do we measure better? How do we define when we say that this new healthcare thing is better than the current standard of practice? What does that mean, better? And so we tend to look for data within clinical studies, like randomized controlled trials principally, but other places as well. Observational data from like studies that are conducted in the real world. We might look at electronic medical databases, the sort of list of automatically collected features that are stored in the healthcare system. Other places where we might get data about whether patients are living longer, if we're talking about life-saving or potentially life-saving or life-extending treatments. We would try to find information about whether or not it improves the quality of your life, not only the length of your life, but are you living better? Or in a case where we're talking about something where it doesn't have a survival difference, like the headache example that I used before, but you're not going to live any longer, but you're no longer in pain. Your pain has gone down, and so your quality of life is better. Other things, reductions in any other unwanted outcomes. So that could be, adverse events from treatment, side effects of different drugs. That could be falls in some cases, or just any outcome, any health outcome that we want to see less of. And so we look for how much does what's the evidence that this new thing actually improves those outcomes that we're looking at. And then we have a similar question for how do we measure what something costs? And that one seems like it would be a little bit more obvious, but there's still quite a bit of nuance to it. We'll sort of look at what are the healthcare resources that end up getting used when we switch from one thing to another thing, and that includes the cost of the new thing itself. We've got, we can use the provincial insurance formulary to sort of figure out, oh, how much does an appointment with this specialist cost or this surgical procedure cost? And then, of course, people do in trial studies on how much things cost. And so sometimes we go to those sources as well. And then we can include different kinds of costs when we consider the cost of a policy change. So we can look at the simple, straightforward healthcare system costs. So that's the cost of medicines. That's the cost of the new the new approach itself. We're talking about staffing time, labor, doctors, nurses, orderlies, et cetera, facilities costs. So if there's new machines that need to be purchased or whatever, we can sort of factor that into the healthcare cost. We also might consider, and a classic example is someone getting a drug as an IV versus someone getting a drug as a bottle of pills that they get to take home. That actually also represents a change in cost. That the costs are not borne by the healthcare system; they're borne by the patient. Patients will have to change the way and how much they have to travel. They may have to factor in childcare or elder care, depending on the structure of their family. If they have to take time away from work, if they're working, that has implications. So there are other costs that we may consider. And then there are societal costs. These are very, very much more complicated and much harder to pin down. But sick people are not good for society. And that's sort of why we have a public healthcare system. It's not good when people are sick at an individual level, but it's also not good at the collective level when people can't function the way that they want to. And so we may consider things like changes in their productivity if they are at work, if they have to go down to reduced capacity, or they have to change the nature of their job. If jobs are lost overall, that people, firms close and things because things shut down. But as you can imagine, it gets very, very complicated once we start thinking about health as an input into the overall societal economy. And then there's this last question of how do we define whether or not something is worth it? And this one is really, really hard to pin down. There is some interesting empirical work trying to figure out how much we are willing to pay for certain benefits that we might get. But it's certainly not straightforward, and it's quite contentious. But I guess the question, just to sort of illustrate the point, how much would you personally be willing to spend to save the life of someone who you've never met and never will? Take that same person, and we're not talking about saving their life. We're talking about just making it 3 months longer. And that's actually a pretty typical window, especially in the space of terminal disease. We are extending life by a short period of time, but we're not curing people. What about if they live the exact same amount of time, but they're in less pain, they're in less discomfort? That question is implied whenever we do this kind of work, is we are asking the public to make a decision about paying for someone else. And the public is made up of a wide variety of people with a wide variety of interests and motivations and abilities to pay. And so we have to think about, when we say worth it, that's not a straightforward question. So why do we use models for this? A lot of the time, because there's so many things to measure, it's really difficult to actually do randomized controlled trials or even observational studies that would take all of this information into account. It's incredibly costly to do that kind of research. RCTs are not cheap. You have to recruit a lot of people, and for rare conditions that affect 1 in 100,000 people, even just the recruitment phase could take forever. And then we have to have sufficient time to follow and observe all of the outcomes to make sure that we have a robust estimate of better and costlier. The healthcare system is not well set up to give us itemized costing information. So that's also an additional piece that we just may not know how much a lot of things cost. That was one of the big surprises when I started in this field. I just assumed that there was an itemized list of things somewhere. There isn't. And then we have ethical considerations. Is it ethical to wait for many years to get better data while people are suffering from conditions now, and there's a treatment that's available today. Sometimes it's not ethical to randomize people to receive something new versus receive something old. Like sometimes there are real other ethical considerations that we have to think of, where it's not conducting a full trial is not the best option. And so we use models as a pragmatic approach to solving these issues. What we do is we'll take the known relationships between events, between outcomes, between a patient's trajectory through the healthcare system, and we will recreate that using software. The idea is that we can try to simulate how people move through the healthcare system, what events they occur to them, what costs they incur during that process, and then any other information that we might find relevant to include. And then we'll as we sort of map out the structure of that, the way that people move will be governed through estimates and sometimes a lot of assumptions about the costs and the percentage of people who experience a certain outcome and the likelihood of certain things occurring. And we'll use that to measure the total impact in terms of costs, in terms of outcomes for a hypothetical cohort of people. And so what we are able to do by making adjustments to the parameters that inform the model, those estimates and those assumptions, we can simulate the total costs and the total outcomes of life, a parallel universe where we have the new thing, and a hypothetical universe where we are doing standard of care. And then we can compare those and we can get our incremental cost, our change in cost, and our change in benefit. And so this is where models really show up, is that we can get some useful information. It's not nearly as precise as a clinical trial would be, but it does give us useful information about what is the likeliest impact of this policy, and how certain are we that this is going to be the outcome? Is it a coin flip that this thing is better, or do we have really, really robust evidence that suggests we're going to get more health and we're going to get it at a cost that we can predict and understand? So just as a quick example, I wanted to show you a model that I built with colleagues at BC Cancer a number of years ago. And this was about using a molecular assay, so a genetic test, basically. The way that oral cancer works is you'll get small growths inside of your mouth, and most of the time those growths are completely benign. They will not turn into cancer. They're just unusual, what are called leukoplakias. But some of them will turn into cancer, and the idea is to use a genetic feature in these cancers, or these potentially precancers, to predict which ones are likely to transform and which ones are going to stay the same. So the current standard of practice is we just don't know. We literally have no idea what's going on inside your mouth. You're going to keep coming back to clinic every 6 months, and we're going to see, has it grown? Has it changed in shape? Has it changed in size? Has it changed in color? And periodically we'll do biopsies and we'll check. And then when we see evidence that it's progressing, then people they'll get surgery, and that will most of those will be locally controlled oral cancers, but some of them will progress and become more serious disease. And so we have this model that sort of simulates patients going to the clinic again and again and again, and then a handful of them entering into this cancer process. So this is the current standard of practice, or it was at the time. And oh my gosh, I have made a horrible mistake, and I have took the new thing is the same as the old thing. But basically, the idea here is that we would apply the molecular assay, and then we would be able to know people who are low risk, they can come in less often. So instead of coming in every 6 months, they're going to come in every 5 years, because the evidence is really strong that people with low risk disease are not going to develop cancer, and we don't need to observe them as often. People with intermediate risk, where it could go either way, we see them every couple of years, but because we know things about the disease itself, we don't have to see them quite as often. And then people who are high risk get surgery immediately. And so what we'll see is there's fewer people coming into they're coming into fewer appointments, and fewer people are actually developing cancer long term. That's the hypothesis. And so we built this model that sort of simulates these two different realities. And then we populated that model with a whole bunch of data. I'm not going to walk you through this. Nobody has time for that. It's in the literature. If you're really, really curious, you can check it out. But you can see that there's quite a bit, there's a lot of data. It's a data heavy process, and we have a lot of information that we sort of incorporate. And it comes from a lot of different sources. And then what we found here is that, as we predicted, we saw a reduction in the number, a change in the pattern of resource utilization in the healthcare system, and that overall we saw a reduction in cost, and actually an improvement in life, in both overall survival and quality adjusted survival, because fewer people were getting sick. So in this case, the decision is real clear. We're reducing costs of the healthcare system, and we're getting more benefits. So not only do we like the new thing because it works better, but it's actually cheaper for the healthcare system overall. That's pretty abnormal. Usually what we see is there's an increase in costs, that we know that it's going to increase the healthcare system costs, and maybe there's going to be an increase in quality adjusted survival. And that makes it very, very difficult to sort of make an easy policy decision. So at CADTH, we get models like this, and they are submitted to us by the drug companies. And they'll submit a whole bunch of trial evidence and other information, and an economic model. And then my team at CADTH takes those economic models and we poke at them, and we prod, and we ask really critical questions to try to get at what assumptions are most influential, what parameter changes are reasonable, are they overestimating the benefit, are they underestimating the costs, so that we can estimate the likely impact if the drug programs across the country did actually fund this new drug. And then we take these evidence, we sort of write this all up into a report, and we take it to an executive committee. And the executive committee, which is made up of scientists and medical doctors, will make recommendations based on the evidence. And so we're talking about millions and millions of dollars of public healthcare funding that gets directly influenced by the work that we do with these models. And it allows us to say yes to some things, and it allows us to say no to some things. But despite the fact that we're doing all of this poking and prodding and sort of deep investigation, we still see an increase in drug costs. Canada is an outlier among OECD peer countries. So do we just keep growing the budget forever? Like, do we just keep increasing and paying more and more and more? Where does that money come from? Another aspect here is that reports are public, but the decisions often get made before the public actually sees the report. And so just to sort of hammer this home, decisions are being made using models that affect the public. Our money, our health is being influenced by these models and the appraisal thereof. And it's an important question to ask. If the public is being affected by these decisions, what role do they have in deciding how the models get made? What role should they have? How much input should we have when we talk about these things, given that these decisions affect us? And then how do we make this information accessible? How do we actually make it so that people can make an informed input to this? And so we brought this question last month to a group of model builders, some of whom are in the room today. Hello, folks. And we just asked these three basic questions. What are the current processes that we use in our work to involve stakeholders? So that's patients, that's the public, that's other groups. Second, how do you feel about that? Like, what is the perspective? How valuable, how useful is that public engagement process? Where are members of the public, where are the stakeholders able to provide valuable input that helps change and inform your work so that it's better and more reflective of the decision context that we're trying to simulate? And then finally, what we talked about, what are people's perspectives on increasing the transparency of these models themselves, making them accessible to people so that they can really see how the sausage gets made, so to speak. And this includes making these models open access so that you or anyone that could log on to a model and see it and play around with it and understand really, like, at a very granular level how well how it performs and what it's predicting and what those predictions mean. And so Sam was with us for that meeting, and I'm hoping to give Sam's hardworking hand a break here, because we've already got a great graphic representation from the last session. And so you can see here, this is the CADTH process that I sort of described to you here. And this is not unique to CADTH. There are health technology assessment agencies around the world that do this kind of stuff. We take patient input from, we go to patient groups, we go to drug plans, we go to clinicians, and we ask for their input. And when the drug companies submit evidence, the health economists at CADTH look through and say, okay, how have these values, how have these preferences been reflected in the structure of the model? We want to see, I think there was a general consensus that we do want these, we do recognize the importance of having stakeholder input, not only not at one place necessarily, but throughout the process, so that we can make iterative changes as we go along. We also recognize that there's a difference between the perspectives that patients bring to the table from the perspectives that members of the general public who are not patients may bring to the table. They have different sets. In many cases, they overlap, but they have different sets of values and different sets of priorities. And it's important for us to be thinking about, well, what are we going to actually do with this information? Are we just going to take it and say, oh, that's nice? Or are we going to actually have a process to incorporate it? How do we make that valuable? How do we make that resonate, so that we're not just asking people for information that we have no ability or interest in actually reflecting in the decision that gets made? And so when we think about increasing the amount of stakeholder involvement in the modeling, we have, that's where things get a little bit more complicated, because we don't have a consistent set of guidelines. It's not something that we have sort of a method for doing. The other thing is that model building is not it's faster than running a randomized control trial, but it's not fast and it's not easy. And we spend a lot of our time just trying to get the thing to work in the first place. Sometimes we have teams of scientists who are working on this stuff for months to get it to work. How do we get patients, what is the reason why a member of the public or a patient or both would bother to participate in the first place? How do we get them to actually come forward and engage with us, and how do we recognize the time and expertise that they're offering us? That's also an issue that we discussed. And then finally, on this transparency piece, there's a lot of different definitions of the concept of transparency, but as I speak to you today, I'm trying to avoid lapsing into sort of health economic jargon and speaking the way that I would speak to one of my colleagues, in terms of, let's conceptualize parameter uncertainty and make sure that we're constructing an appropriate cost effectiveness acceptability curve. And all of that is just nonsense if you haven't spent a lot of time in this space. And so when we talk about transparency, it has to be fully transparent, not only in just putting the information out there, but it has to actually be accessible. And then there are some basic, straightforward logistical questions. Who's going to pay for us to make this stuff transparent? What happens if someone takes work that we do and they use it for a different purpose? Who owns that information? And what are the downsides of making these things fully transparent? Are we sharing code? Are we documenting? Are we writing up? It is in a complex space that we're trying to move into, and that's why I'm so excited about the work that we're doing today, because this sort of points us towards how we can all get the most value out of working together in this way. So really quickly, and I know I'm over time, and I apologize to my colleagues for going a bit over time, but I did want to summarize what we did in the last session. Just to wrap up, the high points here. We use models. Models are the genie's out of the bottle. we are making healthcare decisions based on the results of these economic models, because we are trying to help the healthcare system get the most health for each dollar that we invest in it. It's everyone's healthcare system, it's everyone's healthcare dollars, and so we want to make sure that everyone is benefiting to the highest extent possible. Models themselves are based on assumptions, they're based on estimations, they are themselves a simplification of reality. And as a consequence of that, there's going to be a lot of uncertainty, a lot of subjectivity, and making a lot of judgment calls when, you know, a drug company says that the cost effectiveness is X and CADTH says that the cost effectiveness is Y. Neither of us is correct. We're just using a different set of values. And I mean, pumping my tires just a little bit, I mean, it's closer to Y than it is to X in almost all cases. So, you know, we are trying to achieve this sort of maximizing population health. And then from modelers, whatever sector they work in, I think there's a clear interest in having patients and the public provide us with input and to have your values and your priorities reflected. But there's no clear consensus on how that happens, where that happens, when that happens, and how we make it so that there is actual additional value to the public when we ask them to participate in this process. And with that, I'm going to wrap up. Thanks so much for your attention. This is a topic that I feel really strongly about. I hope I've been able to sort of give you a bit of a background as we start to have this discussion about why this work is important and some of the questions that we're going to try to address together over the next, cumulatively 3 hours-ish. Thanks so much.